Hi, this is Brooke Hensley,
Vicky Noble.
and today we'd like to share with you a case of acute vision loss in the emergency department and how ultrasound can help you bypass a potentially $1 million workup in the ED. So here's the case. I had a 70-year-old woman who was brought into acute for a chief complaint of a sudden onset of right-sided vision loss and floaters approximately 1 hour prior to presentation. She otherwise felt fine, did not have any headaches, no weakness or numbness, or any other neurologic complaints. However, her vital signs were as follows, and you can see that her blood pressure was a little bit up. And the question was, she was sent to acute for a possible stroke evaluation, and do we activate the stroke team?
So one thing you can do is when somebody has monocular vision loss, obviously you're trying to decide whether it's a central or a peripheral cause. And monocular vision loss is very amenable to ultrasound evaluation. And with a quick look with your ultrasound probe, you can kind of make that distinction to see if there's something obvious causing her loss in the eye itself.
And that's exactly what we did. We really wanted to make sure we did the right thing for this patient, and so we wanted to see if we can rule something out going on in her eye. So this was the first ultrasound I did of her right eye, and you can see me fanning back and forth, and this is actually a pretty cool picture because you can actually see her lens and her pupil here on the right side here.
There's the pupil right at the end. That's cool.
And fanning back and forth, and you can see that the gain is up pretty high here, and you can see some echogenic material and debris within the eye, but I didn't see anything really that stood out to me.
And one of the tricky things, the gain is up more than we usually do for things like looking at the bladder because you can see all that posterior acoustic enhancement. But if you're looking for something within the aqueous humor itself, sometimes you really have to, crank the gain as much as you can because it will help you see things that are floating within that vitreous.
Is that safe for the eye?
Well, that's a good question, Brooke, because the caveat we should say is that the eye is actually sonosensitive, and there are some biological effects that can happen, not from a quick look like this, but if you were to turn up the gain and really look at the eye for a long time. So this is one of those clear Alara kind of situations where you want to look with the gain high enough to see what you need to see, but you don't want to overdo it.
All right, so I turned up the gain and I repeated the ultrasound. And here I saw this free-floating echogenic material here, and I had the patient look left and right to see if it was also mobile. And it was kind of wispy, kind of seaweed-like, and at this point I really wasn't sure. I knew something was going on, but was this a vitreous hemorrhage, was it a vitreous detachment, or a retinal detachment? And do you have any points in how I can differentiate the two between retinal and vitreous detachment?
Well, first of all, great job having the patient move her eye because that really helps you see that floating material and that wispiness. And actually, if we go to the next slide, the difference, I think, between a retinal detachment and a vitreous detachment, once you've seen them kind of side by side like this, it's pretty easy. Vitreous is much more wispy, it's free floating, it's kind of not anchored anywhere, it oftentimes just kind of wafting around in the aqueous humor. Whereas a retina here you can see is a little denser, so it has a little more substance to it, it's a little thicker and brighter on ultrasound, and it anchors right there, right next to the ocular nerve at the fovea. And so the nice thing about this is there's actually even more information you can use when you're looking at the retina to decide whether this is a surgical emergency or not. If the macula has been spared, that usually pushes people to do surgery or to repair the retina much quicker because the macula and obviously the vision is spared. Whereas if the macula is off, if the retina has torn through the macula, it's much less of a surgical emergency because the damage has already been done. And the way you would tell that is if this is the probe marker here pointing to the nose, so you have it pointing to the medial side, the optic nerve is kind of right here, and the macula would be just temporal to the optic nerve. And so if the only retina that was detached was this part over here, I would be much more aggressive in getting your consultants involved. Whereas if the retina over here is detached, there's less of a surgical emergency because the macula has already been injured. But the main teaching point for this case is that the retina attaches in the center, and when you move the eye, it's not as free-floating and wispy as the vitreous.
Great. So now that we identified that there's something going on with her eye, we performed the ultrasound. And here's what we did for her. We canceled the labs, the MRI, and we canceled the stroke team activation. And we discharged the patient to the Mass Eye and Ear Infirmary, where she was later diagnosed with a vitreous detachment. And her ED length of stay was only 30 minutes.
Yay, Brooke!
Yay. So some take-home points from this great case are, number one, use the Tegaderm on the eye as a barrier between the gel and the skin to look at the eye. And here's an example.
And actually, I always tell people that the Tegaderm, people worry that when they pull it off, it will hurt the eye, but it doesn't even take off your makeup. It's very, very gentle, so you can even have your mascara preserved.
Oh, great. That's very important. Very important. Number two, make sure to turn up the gain, but only for a short amount of time in order to see very small, delicate structures within the eye, within the vitreous. And don't push too hard on the eye as long as you have enough gel. You don't want to cause more damage to the eye, and so you don't really need to put that much pressure. And to determine the difference between a vitreous detachment and retinal detachment, the vitreous detachment is more wispy and free-floating like seaweed, and a retinal detachment is thicker and anchored on the fovea.
Great job, Brooke.
Thank you for discussing this case with me, Vicki, and please visit our website. If you have any questions at all, please feel free to email us. Thank you.
Thank you.